Everyone, this is Tatiana from New Beauty Magazine, and we are at the Aesthetic Meet in Austin, Texas. And I have with me 4 incredible plastic surgeons who are here to talk about breast augmentation. Dr. Jeffrey Antimarino, Dr. Chet Mays, Dr. Bradley Bengtson, and Dr. Olga Bachilo. So we're going to start with what's new. What is new in breast augmentation? Is there anything patients should know about right now?
I think that there's some new implants that are coming out there. For me, at this point, I use a lot of the Allergan products, and they have some not really brand new, but they're newer to the market in different shapes that I like. So that's for me. Once in a while now, putting in some mesh when I need it for pocket control. So for me, that's a little bit new. The other implants I haven't tried yet, some of the newer ones, we're exploring that. So for me, the implant for Allergan has been sort of my mainstay for about 10 years now.
Yeah, I mean, breast augmentation's the #1 cosmetic procedure in the world. And, as U.S. plastic surgeons, we sort of have limitations on which devices that we can use. And I think as plastic surgeons, embracing the technology that comes out and trying the new technology, as you mentioned, the internal bra, the internal support that we're using now to get some more longevity to our results on some patients, more the active clients who are coming in. And you really want that nice breast pocket, but to use some of that technology to help us out with our long-term results, I think that's something that's exciting to use in plastic surgery.
Yeah, I agree with all those things. Maybe not necessarily new to us, but we've been doing it for a while, but I think it's new to the population. And it's really, I think there are a number of different things that creates a state-of-the-art breast augmentation. So to me, that includes intraoperative or preoperative simulation, imaging and simulation. So patients can kind of see their outcome before or the range of outcomes. I think in surgery, there are certain ways to do surgery. So it's absolutely bloodless. So there's minimal trauma, minimal swelling, quicker outcomes, less pain. There's ways to reduce complications with some of the methods that we use in surgery. Then I think a really important new thing, I've been doing breast ultrasound for a long time, and just have probably ultrasounded 20,000 patients' breasts in the last 25 years. And it is to the level, it is so accurate today that it really gives patients a lot of confidence coming in. So a third of my patients are from 300 miles or beyond Grand Rapids, and they come back for a breast implant check for like 5 minutes, right? So to be able to spend time with them, image their breasts, and our outcomes after about a year don't get better. So, I mean, it's a real positive thing.
Yeah.
You can say, you look great. I mean, your implants are awesome. And, as was said, some of the new implants are designed to last so much longer. I mean, I use Allergan Soft Touch as well. And I ran over some with my Ford F-150 and they didn't break. So they're super strong. They're overfilled. There's going to have less fold flaw. The gel's more cohesive or sticky on the inside. So there's all these advantages in technologies, techniques, and just exciting things going on in breast surgery and plastic surgery.
When you're doing the ultrasound, what exactly are you looking for?
So it's really important we have informed consents for patients. I've never had any medical legal questions about it. The patients know we're just looking at the implant. And
Okay.
So we're not looking at the breast, although I see the breast, see cysts, see different things in there. I'm not a radiologist. All we're looking at is at the implant. We're 99.3% accurate now on rupture or not. I've taken 2,000 patients to the operating room where I've ultrasounded their breasts before surgery, and we're over 99% accurate. Is the implant intact or ruptured? And so it really is taking over. MRI is only about 80% accurate. So it's really taking over. It should be in every plastic surgeon's office for that and other things. But it's great. And it's a great bonding thing. I always tell some of the older patients, I don't see any baby heartbeats here, and these 80,000 or 99,000-year-old ladies that come in, I think they just come in to talk,
Yeah.
but it's very reassuring to have that technology.
It gives you peace of mind.
It does.
Yeah. Dr. Bachilo?
So I think a lot of things have already been mentioned. There's quite a few new devices that are on the market now, new implants, some of which I have not even tried yet, but that gives patients more options. Not every implant is going to work in every surgeon's hands. So patients need to realize they need to not look for a specific type of implant, but look for a surgeon and the type of results they're looking for. because again, that's not one implant fits every patient and not one implant fits every surgeon. A lot of support meshes as well. So as we're seeing more of the weight loss patients that are looking for augmentation, again, we are going to need to incorporate these meshes to produce longevity for the results. And there's a lot more options out there that is very exciting. There's more competition. There's new things coming out every single day. And then post-op management and intra-op management with the different types of tools that are available for us intraoperatively to perform this surgery as safely as possible and to minimize the risks.
Amazing. I'm glad you mentioned the GLP-1 patient because that's been sort of like the theme of the whole aesthetic meeting. Every time I talk to someone, they're talking about the effects of the GLP-1 weight loss and how it's manifesting in their practice. So, and this is another way in the breast as well.
The other thing that we're seeing with GLP-1s is, a lot of times those patients almost act like a gastric bypass patient. So a lot of them are not really adhering to looking to how much protein they're taking in. They're not eating as much. They're not hungry. So their appetite is gone. And what that corresponds to is they're losing a lot of weight, but they're losing some muscle mass, but the tissue itself isn't as good. They're losing some sort of that tone of the tissue. And I think we've seen with the gastric bypass patient, not so much with diet and exercise or with a gastric sleeve, but the gastric bypass patients, again, they're set up, it's almost like a starvation loss, and the GLP-1s are acting like that as well. So I think to your point, we're going to see more pocket problems because the tissue is not going to hold that implant in place like it used to.
Would you like to speak to that, Dr. Mays?
Yeah, no, I mean, weight loss is obviously popular, diet and exercise health, but some of the medications that have come out to help people with their weight loss journeys, we're seeing a little more rapid weight loss, as you mentioned, just sort of the body doesn't have time to recover that. And the breast is one of those areas that you're not just losing volume at time, you're losing that sort of snap back, or maybe the folds are becoming unstable. Like the inframammary fold is super critical during breast augmentation. We've always locked the folds, but these weight loss patients, just there's no stability in their inframammary folds. So to be able to lock it in with like an internal scaffolding or those internal bras just really helps the weight loss patients who've lost that weight so rapidly. You can really give them a long-term result, even with the weight loss.
We just started a weight optimization program in our practice, like a lot of surgeons, I think, are. And the weight loss patient is a totally different patient. And so a lot of the supplementary things to get a good long-term outcome are critical. I always say, I'm talking to patients and other plastic surgeons that whoever controls the lower pole of the breast controls the outcome. So those patients have a lot of stretch deformities. Their tissues are not very good. So they're just going to fail. So they need additional support to hold up the weight of the implant in their breast. So yeah, absolutely critical.
So as we're seeing the weight loss patients, the natural trend that I'm also seeing in my practice as my patients are getting smaller, the size of implants that I'm actually using is also getting smaller.
Yeah.
And the trend is more for leaner, more athletic look. I am seeing a lot less requests for double Ds. I'm seeing more of a more natural, fuller C-cup. Patients really are looking to regain that volume they had before the weight loss, but they are not necessarily looking for much more than that.
And that's actually was going to be my next question is the smaller breast trend. And I know bodies aren't trends, right? But you hear these buzzwords and smaller seems to be where we're going. Do you see that at your practice?
Yeah, absolutely. I think there's been which I like, is this trend away from this idea that bigger is better. And now women are really looking for harmony and they want a balanced breast. And so patients in my practice, they want to have that breast that matches. They don't want to look augmented. They want to have what we call the natural breast, which is in the American view, that breast is balanced from top to nipple, nipple to bottom, or side to side. So that it's pretty round, but they don't want that sort of that what we call that donut look. They want a very nice gentle contour. So for me, over the years, switching over to a little bit more profiled, balanced, a little bit more narrow, better fill, it gives you that really nice soft look. And so when I talk to patients, I tell them I want them to look elegant, not augmented. And my patients really follow that. And so when we size them in the office, there's a big trend now to 225 to 375, 400. We're getting away from all of those huge implants that just make them look bulky or fake over time.
Yeah, I mean, when it comes to the breast, I mean, four great breast surgeons here. We're all very good at doing breast surgery, but it's about patient expectations, right? Managing their expectations of what their breast will look like after. And as you're in consultation with the patient, they're sort of telling you what they want. But I like it when patients show me, like I call them wish pics. They'll bring in a picture of what they want.
Right.
And definitely a lot more now recently, more of the pictures they're showing me, these do not look like augmented women. They look very natural. They fit the frame of the individual, which is good because the longevity of that result with a smaller, especially if you're using an implant, longevity of a lighter implant, putting less downward force on the body will have more of a long-term result. So when patients bring in those wish pics, I always love it when they have that nice natural picture that I can't tell whether or not the patient has an implant. It's like, oh, we got this. This is going to be really good.
Yeah, I absolutely love this trend. The cool thing about it is we've always been a practice, our brand is natural, proportional, not overdone, over big, over large. And, our motto is the best plastic surgeries in patients you can't tell have had it.
Right.
So the whole market is coming back to that now, which I think is great.
Yeah.
It's kind of where we've always been. So it's really, kind of, I think, going to be supplementary to what we're doing. And yeah, I mean, they're right. It's the newer implants on the market are going to allow us to potentially go back above the muscle and have less capsular contracture, less tightness, scar tissue around the implant. And I think the other thing is with Manuel, some of the people that have all this experience with these new implants, you're actually able to place an implant in an area of the breast. And so far, it's above or below the muscle. It's an all or none effect, right? And you don't want to go too big, but the future is really going to be putting an implant in a specific area of the breast where you want it, usually more on the inside and higher. And it's very different, but very exciting for our patients.
So I like that idea of having the patients also show us the pictures. I usually ask patients for their not even pre-op, but consultation, bring at least 2 to 3 photos to show me of their kind of ideal result, because it's surprising how many women do not know what a C cup or a D cup is.
Yes.
And very often they'll bring me pictures that will range even from B to a D cup, but there is some element of each of these photos that they like, whether it's that upper pole, whether it's the roundness of the breast, whether it's the height of the breast. And there are certain things, of course, we can't change, the height of the breast. So that really opens to the discussion with the patient of expected outcome. Again, there's lots of implants available, and I know some surgeons that may be using high to ultra high profile implants, and they use that across the board, regardless of what the patient is. It's not one implant fits every patient. I tend to stay more on the lower profile implants, moderate profile implants that is going to give patients more of the looks that they're going for, more natural.
You mentioned bringing in photos. Is there anything else that a patient should do? Obviously, come in, feel the implants. How do you know what is going to fit right for your body, the right size, the right shape? What other tips do you have?
I think the biggest thing, as you get, more experience, listening to what they're telling you. And again, having them with the ones that they want, that shape that they want. And the one thing I get my patients to not discuss is cup size. Because it has, you can't make somebody a C or a D across the board, because bras don't follow that old guideline anymore. So I get them out of their head, and we just look for shape. I have them try on implants in the office with clothes on, with like a form-fitting t-shirt, so they can see the change as they go up. And then as we go through that, I have a way to sort of get them to where that's what they like. And so I don't tell them anything about the implants. I don't tell them the different shapes, the different styles. We choose that. But as far as the volume, I don't bias them, because they always come in saying, well, I looked at so-and-so's website and this lady had 375s, or my friend came to you, she has 420s. That's what I want. So, and I tell them, unless you're a direct clone, it doesn't matter. You might like her look, and we'll do what we can to give you your body look, but you're an individual. So, what we're going to do is just try on implants with the shape that we chose that you like. And then when you see that, then we'll know. And for me, I always tell them, then I know the volume, and that's better than me trying to guess what a C or a D is. So I try to get them, and I tell them, don't let a letter define you. It doesn't really matter what letter. You could be a Q, for God's sakes, but if you tolerate that. So I go by base width, and that's sort of my limiting step. But up until that point, they can try as large as that diameter can hold. And but I find that works better, and then patients are a lot more open to that and less anxious, because the first thing they tell you, right, is I don't want to be too big. And I always tell them, you're going to pick it. I'm only going to guide you. You get to pick. So, and I tell their husbands or their boyfriends, you are just a silent partner in all of this. Her opinion is the most important. Second is mine, and you're just here. Right. So
That's good advice.
That's how I tell them.
Yeah, and I'm similar with my patients in consultation, having them try on certain implants in a sports bra with a top on, just to see what that look is. Because like you mentioned, they'll come in, they might have cruised the website and saw, oh, that 415, I love her breasts. It's like, well, how tall are they? How broad are their shoulder? Like, what are the measurements of that person who has a 415? Because a 415 in 3 different people can look 3 different ways. So it's a lot of education of the patient. Like, don't get hung up on the size of the implant or the cup size. I agree. Like I say, I don't make bras, I make breasts. So don't quote me on the cup size. I actually have a coffee mug says I don't make bras, I make breasts, because a C cup could be many different things, but I'll tell them what I think a C cup is. Or if they're trying something else, like, to me, that's a C cup. But if you go to Victoria's Secret, you might be a D or double D. And it's just about educating them and letting them, I think, trying that on, see how heavy that actually feels, right? A 3cc implant does have weight to it. So they need to know that that is the weight of what they'll feel in their body. So as much information as you can get, because I go to the operating room, unless there's an asymmetry, I'm going with one implant to put in. I'm not going in with sizers and sizing things out to what looks good, right? We've pre-committed to what we're doing, unless there's an asymmetry or something where I might need 2 different sizes or 2 different profiles, or there's times I'm using 2 different cohesivities of the silicone, because they might have a depression on one side and a prominence on the other of the bony structure underneath. Being able to play with the technology to give a symmetrical result. I think more often than not, I might be using 2 different sizes of implants, because we're all a little asymmetrical, men and women. So trying to give them that symmetrical look is just about listening to their goals and just not getting caught up on cup size.
So I take a little bit of a different approach. I think all of us use a little bit of a implant planning or selection sort of a tool or evaluation. Caroline Glicksman and I actually did a study to standardize the bra cup. So for me, I ask them what bra cup they're in, and I tell them we're talking foreign languages with each other. There is no standardized bra cup, but we studied about 20,000 patients, and I can tell you, to me, an 18 centimeter hemicircumference is a B. And so when I measure your breast, that's what you are. And so the second thing we say is it's like the Price is Right game that has a fridge at $695 and that red bar is going across. We're just talking about a range. We're not talking about a specific implant that's best for you. There's probably 10 that will work over 150 cc range, right? So we go through that. And then actually we use Canfield Vectra simulation. I think it's super important because the surgeons are right. You can't look at someone else's breast and then try and figure out what's best for you. But a simulation is, I think, the best to help us navigate implant selection with patients. And we actually have them sign off on a number of different things that talks about breast asymmetry and all that. And so I've done very few size changes. It used to be one of my most common operations. So it's virtually eliminated that.
So one of the most important measurements I take is their breast diameter. So that's going to judge how wide of a footprint my implant is going to need to be. After that, we can kind of play with the actual projection of the implant, which is going to be the cup. And so we'll have them try different implants in their bra. And usually I'll start from smaller and kind of taper up based on what I already think may be their wish. And then as the patients, try the implants, I'm looking for their expression in their face as they're looking in the mirror and judge, are they excited? Are they kind of hesitant? If they're hesitant, I ask them why. After, very often patients will put on that first implant and they're like, I'm in love, this is it. I offer them to try a different size. They don't even want to try a different size. And sometimes if I feel like they need to, I will encourage them to do so. But when I see patients that are starting to hesitate between like a 300 and a 325 cc implant, which I mean, 25 cc's is negligible. I can put one of each on the breast and they will never know a difference. Then I do tell them as a guideline. In most of my patient population, it's going to be about 150 to 200 cc's to even see a cup difference. So I give them it as a guideline. That 25 cc, even a 50 cc is not going to make a huge change. So at the end of our pre-op and consult, we usually select a range, and it's a 100 cc range. I say we're going to be between 300 and 400 cc's. That way, I don't guarantee them a specific size implant. It's going to be one in between there, and that's what is going to give them the look that they're looking for.
It's such an important decision for so many people because it's in your body for such a long time. So I appreciate your insights and sharing all of your knowledge with us today. And for the patients who go to see you, we know that they're very lucky to have the best surgeons in the world doing their breast augmentation. So thank you for coming to NewBeauty and sharing your insights with us. Thank you. Have a great show, everyone.